is Dr. Seroussi. It looks like it's September 19th. And I have our patient here, Michelle Beck. And Michelle, I'm gonna just talk a little bit about your injuries today. And you can give us some input as well. And then we're gonna do a procedure, and I wanna just show what that's like. Okay. So you got an injury back in March 2019.
Yes.
And you're having ongoing pain, more on the right, if I'm correct.
Correct.
And do you have headaches as well, or?
Yes.
So you said pain in this area, and where do you feel the headaches?
Mostly in the front, sometimes like a band around my head, but typically bothers me mostly in the front.
Okay. And there's been some concern about a possible shoulder injury. Sounds like that's not as big a concern for you.
No.
But there is a concern that your arm has been falling asleep at times. It's hard when you bring it up. Is that correct?
Yes.
So we did one scalene block before, which is I'm going to pan over here. This is a model of skeleton, and scalene motor blocks are used for a condition called thoracic outlet syndrome, where there's the bundle of nerves as they come out of the neck, the so-called brachial plexus, ends up getting pinched between two well-known muscles, the anterior and the middle scalene muscles. So what we did on that date before, and we're going to repeat it today, is we put some anesthetic into this muscle, the anterior, and kind of gave you breathing room, sort of like slackening a rubber band. And then you could feel your arm much better, and you got stronger, and you could tolerate overhead. Unfortunately, it's worn off.
Yes.
And what we'll do is we'll try it again today. We also did another muscle on that date, the pec minor, which is not shown here, but it's a muscle that goes between this part of the scapula to the chest wall. And that can also pinch this bundle of nerves, the brachial plexus, as they come out of the neck and into the arm. So those are two pinch points. One is kind of there, and one is kind of there. And it sounds like the brachial, the one at scalene is a little more notable. And there are other classic findings. Put your fingers apart here. Hold them apart. And typically what happens is that gets a little weak on that side, and some of the small muscles hold it up a little stronger. There we go here. And a little weaker. And when you bring your arm overhead, not so great?
No.
Okay, we're not going to do all that today. But
okay.
Suffice to say, we've done a workup. We think that's at least part of your problem. My concern in your case is that you have other injuries. You know, when it comes to trauma, the patient has as many diseases as they pleases. In other words, trauma is different than all branches of medicine. Most of the time in medicine, we try to find the one unifying diagnosis, but when you've had trauma, when you've had an injury, several structures can get hurt. So commonly, another structure that often gets hurt, or structures, are the facet joints. Facet means side, like sides of a diamond, right? And these little facet joints, these little flat-sided joint, little flat joints. And we call them facet joints. And they're often injured. They show up on MRI scans, but injury to them or pain from them doesn't. And so typically, like that level there, that's been sore for you before. Is that correct?
Yes.
Is it sore today?
Yes.
So we haven't done a workup yet. That's the C2-3, or the upper cervical facet joint. But another step we would take in Shelley's process here is we would do anesthetic or diagnostic injections under a moving x-ray, fluoroscopy, moving x-ray. And if those diagnostic anesthetic injections gave immediate benefit, we would look at more advanced treatments. They'd sort of confirm what I think is going on clinically. You've also had some treatments for the lower back, chiefly the sacroiliac joint. And I'm going to put that in English too. Sacrum is the spine, and ilium is the hip. So it's the spine-hip joint. And these blue structures here represent the ligaments that hold that joint together. Actually, in my model, it looks like the joints come apart already, but this is the kind of thing we try to work on when patients have had injuries in this area, in the sacroiliac joint area. And Dr. Brand did a PRP injection. There were some problems with it, but I think if we were to try to convince you to do that again, and I know it was fairly traumatic for you, what we might do, probably would do, is put it under fluoroscopy, which is a little more easy to pinpoint that joint. So I don't want to get ahead of myself, but okay. I just want to give an overview of what these injuries have been for you. Yes. Not all of them, but I'm talking about sort of the main things. I know you've had trouble with prolonged computer activities. You're in sort of accounting, bookkeeping, accounting sort of thing. There are other things going on, but these are the main things I want to touch on. Does that make sense to you?
Yes.
The last thing I'll say about the SI joint, another joint that shows up on MRI, but injury to it or pain from it does not. I know there's been some concern about a possible disc herniation here. That's a separate issue. But these joints here, the SI joint, the facet joint, even the brachial plexus pinching from TOS or thoracic outlet syndrome, all these structures show up on advanced imaging, but generally we can't detect imaging abnormalities by imaging. We have to use our hands, our brains, our clinical experience, the peer-reviewed literature, and finally diagnostic and confirmatory injections. Does that make sense?
Yes.
All right, I'm going to cut that here, and then we'll do the procedure. Thank you. I have Shelley here. We've prepped this area with betadine, and this is an ultrasound probe. I think the camera also shows the ultrasound, and this is a needle for injecting. Emma, can you, so this is towards the midline. Emma, show them where you believe the vessels are. I'm putting you on the spot, Emma. Sorry, yeah, that's the internal jugular, and the one that's non-compressible is the carotid. Why don't you put on Doppler just to confirm that? Yeah, color flow. Yeah, there you go, and there's the flow pattern. And then let's turn it off again. I don't really need that. I'm going to go a little lateral, a little to the outside. And the brachial plexus, let's see, can you cap that or just hold that for a second? I'll just show the scalene muscle here is right here. That's going to be my target area. That's that muscle I was showing in red, and now it's going to be in cross section here. That's the brachial plexus. Looks like a bundle of grapes, and that's the middle scalene. So that's my target area to relax. Okay? I'm going to do this on what's called out of plane view. Okay, Shelley, you okay?
Yes.
All right. A bit of a poke here. And there's a little wiggle. Emma, do you see the wiggle? A little lower. There it is, right there. And then I'm going to inject, and that's the injection. Okay. A little hard to see if you're not used to seeing it, but when you've done a few thousand of these, you focus on it right away. You okay there? You hanging in there?
Yeah.
Most painful part of this is listening to me talk. All right, that's just about done. I'm going to give you 60% of the injectate there. So that's been injected in the anterior scalene, and the pec minor is a little tougher sometimes. Emma, can you make that a little deeper? Yeah. Okay, and then, yeah, that's good. Minor's a little harder to detect sometimes. Pec major is the upper one, and pec minor is below that. It's pec minor not because it's an insignificant muscle, but because it's below the big one. I'm going to just go here. And again, I'm just going to poke. I'm sorry. And I'm going to go. There I am, right there. Can you see it, Emma? Right there. You're getting better at this, Emma, I must say. Sorry about that, Shelley. Okay, and that's it. We're just going to clean that area. We'll have you get up, and we'll see how you... So we're still just a few minutes later now. You got you dressed and everything, you're up. And we're still less than probably 5 minutes from when I did the procedure. And that arm,
Feels better.
you can tell already.
Yes. Yes.
Yeah. And I didn't do the whole testing I normally do before. I do a bunch of testing, but we've done it before. Fingers apart. Here's the interesting thing is often the intrinsic muscles get stronger, these little guys. These fine muscles of the hand. The left is still kind of affected. You do have some left-sided stuff, but it's not as bad as the right, is it?
No.
And the right really has still a little weakness, but better overall. You feel that?
Yes.
And you feel the tolerance to the overhead.
Yes.
The concern I have is oftentimes I treat here, but this might still bother. And so you can have 2 or 3 things going on, and that's often the case, especially in the chronic setting. You know, it's been over 4 years. It's usually not super simple at this point. I don't know if the shoulder's that bad. That's kind of good news because I thought you had more of a shoulder problem before. I didn't test it earlier today, but it seems like the shoulder's not a big story to tell here.
Not really.
Yeah. It's more about the arm and the neck and the headaches and that sort of thing. Is that correct?
Yes.
Okay. I think that's it. We won't cover the low back today. There's a lot to cover. I just wanted to show kind of what we do here.
Yeah.
And how we get from A to B, how I get my answers.
Mm-hmm.
Unfortunately, I can't just rely on a $2,000 scan to tell me what's wrong with you. I got to use these guys and these guys.
Okay.
And then the confirmatory injections.
Okay.
Any questions for me?
No, I don't think so.
The one other thing I say is, so if this doesn't last again, then we talk about things like putting botulinum toxin or Botox in there. There's a whole stepped approach. I don't really want to go there right now.
Okay.
But we'll take it a step at a time.
Okay.
All right. Thank you.